My name is Andrea, and today's topic is going to be Volanesorsen and triglyceride levels in familial Chylomicronemia syndrome. First, we have my social media, Twitter, YouTube, Facebook, and Instagram. Let's start with definitions. What is familial Chylomicronemia syndrome? It is a serious disease that prevents the body from breaking down fats. Eating even a little fat can make someone with FCS ill, and the condition causes chronic symptoms and can lead to potentially fatal pancreatitis. FCS is a genetic disorder passed down from parents.
So familial hyperchylomicronemia syndrome, otherwise known as FCS, is a syndrome diagnosed usually early in life, oftentimes in early childhood, more often later into childhood, or in some cases into adolescence and adulthood, associated with extremely high triglyceride levels, usually almost always greater than 1,000 milligrams per deciliter, often into the 2, 3, and even higher thousand. Also associated with a variety of other clinical symptoms. It can be seen and associated with an eruptive rash, we call that eruptive xanthoma, associated with recurrent abdominal pain, GI symptoms, and recurrent pancreatitis, enlargement of the liver or spleen, hepatosplenomegaly, and in many cases, this can lead to a chronic form of recurring pancreatitis that can alter life and in some cases be life-threatening. The diagnosis is made by measuring triglyceride levels, by the clinical presentation, and by the family history, as this is an inherited condition.
Okay, so next we have applications in medicine. After a 6-week diet stabilization run-in period during which patients were asked to follow a diet that included less than 20 grams of fat per day, patients with fasting baseline triglycerides level of 750 milligrams per deciliter or higher were randomly assigned in a 1:1 ratio to Volanesorsen at a dose of 300 milligrams per week or placebo. Volanesorsen or placebo was administered as a single subcutaneous injection once a week for 52 weeks. During the trial, a reduction of dosing to once every other week was allowed in unacceptable side effects or adverse events occurred. The primary endpoint was the percentage change in fasting triglyceride levels from baseline to the time the primary analysis was performed at the end of the month. The fasting triglyceride level for month 3 was average of fasting assessment made at week 12 and week 13.
Well, someone can have high triglycerides and have no other symptoms. In fact, that's why many people do fine for a while. But the symptoms are most commonly related to the pancreatitis. So severe mid-epigastric abdominal pain radiating to the back, and they can often present in childhood. So certainly children have this condition and often are not diagnosed with it. Skin findings can occur. So a particular type of skin called xanthomas, eruptive xanthomas that come out on the skin. Of course, the most distinguishing feature is, in fact, the high triglycerides, which, when they're high enough, can actually make the blood look a bit creamy in color. And that's sometimes the first time this is identified is when a child or an adult with this condition has blood drawn, and their blood is a bit curly or creamy in color, is a tip-off that they have this condition. Before an individual with FCS has pancreatitis, this is basically a silent condition. People have high triglycerides but don't know they have high triglycerides, and in fact will not know unless they actually get them measured as part of a screening test. So this is often an underdiagnosed disorder, especially prior to the first episode of pancreatitis, because it's silent. It's not causing any symptoms, and someone would have to have a blood test and specifically have triglycerides measured in order to pick it up. So that's really the big tip-off is that high triglycerides on screening. Of course, unfortunately, many people don't get diagnosed until they have their first episode of pancreatitis, which should definitely tip off the possibility of this condition But of course, that first episode of pancreatitis can be very severe, and in some cases, regrettably, can be fatal.
Okay, so next video.
Management of FCS is a difficult management proposition. And the reason for this is that people with true FCS do not respond very well to traditional triglyceride-lowering medications. The treatment of choice is essentially severe fat restriction, which is not easy for most people to do. And so a team approach to this is key. That means not only the healthcare practitioner, the physician, the nurse practitioner, often a pharmacist has to be involved, but probably key to this whole group is a good registered dietitian. Because getting people to eat extremely low-fat meals and low-fat diets is not an easy one, and many people have to self-prepare most of their meals at home. And understanding how to cook and how to prepare, and how to eat meals outside of the home that have low-fat content is one that can be very tricky. And oftentimes people will go out and they'll ask for something to be prepared, not in fat, not in oil, not with butter. And you know as well as I do, behind the back in the restaurant, they're using that stuff anyway. And so many of these patients are actually limited to whole-based preparation because of the concern of what will happen if they go out and eat the wrong food. So right now, it really does require support from many individuals. And it's that team working together that helps us control these patients and manage them so that they don't end up in the hospital with pancreatitis.
Okay, so next we have pros and cons. Pros and cons. Volanesorsen lowered triglyceride levels irrespective of the patient's genetic diagnosis. At 3 months, mean triglyceride levels were decreased by 65% in 17 patients with allelic mutations in LPL and by 75% in the 9 patients with non-LPL genetic deficiencies. Patients with mutations in APOC2, PPIH, DP1, APOA5, and LMF1 all showed marked triglyceride decreases by 69% to 88%. Treatment was also effective irrespective of baseline triglyceride levels and was equally effective in patients receiving baseline N3 fatty acids, therapy, or both, and patients not receiving those therapies. So information 1, and then information 2.
That we found among other patients who had sick. We also recently published our data on extreme hypertriglyceridemia from children at that. And we were surprised to find that there were patients with familial chylomicronemia syndrome that we found among other patients who had secondary causes for extreme hypertriglyceridemia, like diabetes, uncontrolled. And we were surprised to see the prevalence, estimated prevalence in adults was much more than what is written in the literature of 1 million. We think that familial chylomicronemia syndrome may be more prevalent than what is so far recognized. And what we recommended in the past is that we should look at what is called as neonatal screening. So we recommended in our article that maybe it is time for us to do neonatal screening for familial chylomicronemia because potentially it is a treatable disease. Most of the time, these children, when they are born, they are not recognized with that familial chylomicronemia. And even if they are on breast milk or they are on formula, and that causes extreme elevations of triglycerides, and that can be potentially dangerous for people. So I think I would say that we have to treat these people. And beyond that, recognition of syndrome, and other therapies as they would be very,
Okay, so now information too.
Steve, what causes familial chylomicronemia syndrome?
The underlying problem is that the enzyme that breaks down these chylomicrons, these packaged fat particles, it's an enzyme called lipoprotein lipase, or LPL. And in patients with familial chylomicronemia syndrome, this enzyme is not working correctly. As a result, these chylomicrons are just circulating in your blood as you absorb fats from your diet, and these levels get to be extremely high, and as a result, you can now have diseases such as pancreatitis that will then occur.
I also think that it's important for patients to know that the normal level of triglycerides is usually below 150, and patients with familial chylomicronemia syndrome usually have these levels above 1,000. In the recent publications, they say 885, but in reality, there are 1,000, 5,000, 8,000, and that's what we mentioned, and that's what we mean, having very high triglycerides.
Exactly. And we know that as the triglycerides get over 1,000, your risk of pancreatitis continues to go up. One clue, even if the triglyceride level was not ordered on a blood test, a clue that someone might have familial chylomicronemia syndrome or other causes of very high triglyceride is that your serum or plasma, so when you spin down your tube of blood, it will look like a milkshake when you look at the plasma or serum. It'll be milky and thick. And when you see that on a report from the lab, it would say lipemic syndrome or lipemic serum. That's a tip-off that your triglycerides are very high, and therefore there should be formal testing for that.
Okay, so next we have issues of life in Ecuador. There were no reports of Volanesorsen increased levels in familial chylomicronemia syndrome in Ecuador. Finally, we have conclusions. Volanesorsen lowered triglyceride levels to less than 550 milligrams per deciliter in 77% of patients with familial chylomicronemia syndrome. Thrombocytopenia and injection site reactions were common adverse events.
We're enrolling in a phase 3 clinical trial for familial chylomicronemia syndrome. Patients with FCS have excessive levels of triglycerides and are at risk of pancreatitis and recurrent pancreatitis, which could be life-threatening. ApoC3, which is our target, which we knock down with our drug, actually impacts the clearance of chylomicrons, which are packets of triglycerides from the blood. And so the hope is that we were able to knock down the ApoC3 and therefore the triglycerides and prevent pancreatitis in these patients. And we're also starting a second clinical trial with the same drug target for knocking down ApoC3 for patients with familial partial lipodystrophy. The patients with familial partial lipodystrophy have defective adipose tissue that results in significant metabolic manifestations, including high triglycerides and high ApoC3. The patients have high insulin sensitivity and subsequent diabetes, and actually end up many times either with life-threatening pancreatitis or liver disease or cardiovascular disease. And so by ApoC3 is our target for ApoC3 is to knock down the triglyceride level and their risk, therefore, of these severe disease manifestations. And that trial will be up and running later this year.
Okay, so that's it for today. Thank you for watching.